So welcome to the Seeing is Believing Southeast Asia and Western Pacific Regional Webinar. My name is Susan Evans and I'm the Seeing is Believing Project Officer for IAPB. Thank you all for attending today. I hope you and your families are all keeping well during these challenging times. I'm aware that COVID-19 has impacted all of our lives and I really appreciate you taking the time to join us and be part of our learning community. The theme of this Seeing is Believing webinar is Child and School Eye Health, and we have some fantastic presentations for you. We have over 60 people registered from 10 countries in the region, which is fantastic. Our audience today are SiB project implementing partners, and for the first time, we've opened up our SiB webinars to the wider IAPB membership. So if this is your first SiB webinar, you are highly welcome. And if you've attended before, it's good to see you again. If you would like to introduce yourself to the group today, you can write your name and which country you are from in the Q&A. I would like to give a big thank you to our webinar presenters. Yuddha Sapkota, Regional Coordinator, Southeast Asia, IAPB.
Hello, everyone.
Guan Chunhong, Senior Programme Manager, Orbis International North Asia.
Hello, everyone.
Wardhana Dipa, Senior Project Coordinator, Eye Health, Helen Keller International.
Hello.
Dr. Satya Kotha, Head of Programs, Eye Health, Helen Keller International.
Hello.
And we have Satya just on audio because of the connectivity. Yeah, and Sally Crook, SiB Programme Manager, IAPB.
Good morning, everyone.
So the agenda for the webinar today will be welcome and housekeeping notices, which I will do. And then there'll be an introduction to the opportunities and challenges of child and school eye health in the Southeast Asia and Western Pacific regions by Yuddha Sapkota. Next, presentation on child and school eye health in the Orbis China Child Eye Health Seeing is Believing project by Guan Chunhong. Presentation on child and school eye health in the Helen Keller International Indonesia Child Eye Health SiB project by Wardhana Dipa. After the presentations, I will chair a question and answer session. Finally, Sally Crook, the SiB Programme Manager, will make some concluding remarks. And this webinar should take around 1 hour. So firstly, some housekeeping points. Each presenter will share their screen during their presentation. Microphones are muted apart from the speakers, as this ensures a better quality webinar. We aim for this session to be participatory, so if you have any questions for the presenters, please type them in the Q&A. My colleague Holly is supporting us today with technical issues, so if you have any technical difficulties, for example with sound, you can just send us a message in the Q&A, and thank you, Holly, for your support today. It's a good idea to close down all other web applications, for example, Google, Outlook or Skype, to get a better quality of call. And if you have headphones, please use. I'm recording this webinar and it will be uploaded onto the IAPB website, and I'll send around the link in a few days. Finally, at the end of this webinar, I will be sending you a survey for your feedback. So the theme of this SiB webinar is Child and School Eye Health. The presenters will share their learning from implementing child and school eye health Seeing is Believing projects, and we hope that listeners will be able to identify strategies you will be able to implement in your own contexts. We are aware that due to COVID-19, many eye health activities are suspended and many schools are currently closed. In her concluding remarks, Sally Crook will share some resources on child eye health and COVID-19. I'm now pleased to introduce my colleague, Yuddha Sapkota, the Regional Coordinator for IAPB, to give an introduction to some of the challenges and opportunities of child and school eye health in Southeast Asia and the Western Pacifics. Yuddha, over to you.
Yeah, thank you, Susan. First of all, yeah, thanks to the SIB for organizing such a wonderful webinar and the very relevant topics now globally. So I am Yuddha Sapkota, working for the IAPB Southeast Asia, and that I'll just give you the brief introduction of our region, what the situation is. Yeah, overall, we know that this vision-related quality of life children will be, is a very much problem in the developing world. We have the vision impaired child or the blind child will have a lot of compromise, and then they have all the problems, and then they all are mostly they are found in the socioeconomic deprivation area, and then the developing world. So it has become a kind of the big socioeconomic burden for the community, in the family as well as the community. And then so we have all the issues related to this problem, such as screening of those children, and then providing the cost-effective interventions, and then also the screening tools. All those are all the difference, and then found are the challenges in this issue. Though maybe I will start a brief of the childhood blindness. I will touch a bit, and then I will go to the vision impairment sections. So the introduction of the childhood blindness is a kind of it's not a big burden. It's a big burden, but if you count as the blind years of the children, so that will affect affect a lot of blind years. So that is become the huge problem in terms of the blind years as a second to the cataract. So that is the thing. So the childhood blindness is the world global data shows is in a decreasing form because of the childhood mortality is decreasing, as well as the childhood blindness is also in a decrease. According to the data, we had a kind of estimation of the 1.5 million children were blind in 1990 decades, and then which has estimated as now as a 1.14 million blind child now in the current years. So those are it's a kind of the decreasing. But this childhood blindness prevalence varies region to region, and then it's more of the problem of the developing part of the world. In our part of Southeast Asia is more of the problem. And then also the causes are the kind of the cataract, corneal opacity, uncorrected refractive error are the major cause, and then the genetic and the other problems are also there. Now is increasing challenges for us is a retinopathy of the prematurity, also increasing in the developing world because of the more developed healthcare service, NICU and ICU things. So in the developed world is more of the cerebral visual impairment, optic nerve diseases, but we have more of the avoidable causes are there. And also in the some part of the our region is also still the vitamin A deficiency, ophthalmia, neonatal harmful traditional practice, traumas are the major regions. So this is still decreasing vitamin A deficiency problems, but it still remains in some part of our region. So it is just to go by the country wise, the recent data shows that the kind of in India is a kind of 0.8 per 1,000 children are blind. So and in Indonesia is this is blind and severe visual impairment is a kind of 0.25%, and then one third of is still cataract, and the majority of the blind and the severely visually impairment in the Indonesia is a kind of 1/3 is still cataract, and then there is other are the globe, retina, and the cornea problems. It shows. And then one of the issue is that we have a very problem of the availability of the childhood blindness data. Also, most of this data are collected from the blind schools, and then as such, childhood blindness survey is not taking place because it's a very expensive exercise, and then the problems in related to the other cause of the blindness is adult blindness. I mean, compared to the adult blindness is a smaller part, so it's not adequate priority is given for the blindness survey. So the data collects from the blind school, and all the blind school data collected, like in Myanmar, shows that even the people admitted in the blind school shows that the 1/3 of this were avoidable cause, and then were mainly cataract. So does the Sri Lanka blind school survey shows that 17% of the blind were due to cataract of avoidable cause. So and then similarly, the Bangladesh also the leading cause of the childhood blindness, they say, is a childhood cataract, the congenital cataracts. So the focus area in the childhood blindness are the refractive error, retinopathy of prematurity, the emerging epidemic, and then cataract still persists. And then there are the retinal dystrophy and optic nerve disease that also in the developed world. And then the other thing is the area is which requires the low vision and rehabilitations. And then the problem is the quality of life is compromised and the assessment tools are not readily available. These are the thing. And then also not to ignore, as I mentioned earlier, this is a vitamin A deficiency, ophthalmia neonatrum, cortical visual impairment, and the trauma are the issues in the childhood blindness sections. So the refractive error, also the similar problems, the magnitude of problem of the refractive error also shows more in our part of the world, mainly the Pacific region. The childhood, the refractive error, both the children and the adult refractive error, and then uncorrected refractive error is a huge problems. One moment, just looking at the notes. So looking at the problems of the refractive error in the adult also is a problem. Like the China 9 provinces study shows 5.4%. Arvindra Comprehensive Eye Survey shows the 3% of the adult has a refractive error. Tirunelveli Eye Study 19.4% of the 4%, and the Bangladesh Eye Study shows 20%, and Andhra Pradesh children's 4.4, and then the above among the adult among the 20%, and then presbyopia is another big issue. It shows. And then India, other study like Rajasthan, 11% uncorrected refractive error, and Shiva Ganga India study shows also 26% in the some part of the South India has a uncorrected refractive error. But it's more in the Pacific region, as I mentioned, the Hong Kong study shows the 51% are the adult are impaired, vision impaired, are due to refractive error. Among the vision impaired, 51% were the refractive error. So other children study like a refractive error in school children or the school going children shows also the similar pattern of the prevalence, like Nepal in the urban shows it's a 10% in the age of the 9, and then it goes to the 27% when children reach to the 15% in the urban school children. Similarly, Beijing myopia study shows kind of 36% among the 10 years old, and then goes up to the 55% when the children reach to the age 15. Similarly, another study in China, Guangzhou myopia study reaches to the 73% when the children reach to the 15%. So this way, the problem of the refractive error is a huge problem there. In the Malaysia also 9.8% at the age of the 7 and increases to the 35% in the age of the 15 years old. And then another study shows that Singapore, among the students who are in the technical stream, who do the most of the prose work, has a 70% of them were visually impaired due to the refractive error. So all this study shows that there is a huge magnitude of the problems globally. Similarly, our IAPB Vision Atlas also estimated the myopia epidemic in the years to come, and then estimated as 40% among the children in the 2050 simple myopia, and then another 10% additional for the high myopia. And then World Report on Vision also is been highlighted the problems like a 2.6 billion with the myopia, and then 312 million.
Yuddha, thank you. That's great. That's a lot of data, a lot of information. Now we would like to hear about the solutions for all these problems that we know are out there. So could we? There's a lot of data, and people are asking for the numbers. So maybe if you'd given, a fact sheet or something we could hand out, great. But could we get on with the presentations now?
Okay, thanks, Sally.
Thank you, Yuddha. Thank you for giving us that. Really, the overview of the scale of the problem. Actually, actually what we do need is some examples of now, you know, what we can do. So thank you, Yuddha, for that really comprehensive introduction to the topic. Thank you so much for that. So for our first presentation, let me introduce Guan Chunhong, the Senior Programme Manager for Orbis International North Asia. And Guan's going to share her screen now. And so for the rest of us, we can stop our videos, and then so the viewers will just see the PowerPoint presentation. So Guan, over to you.
Thank you, Susan. Good morning and good afternoon, everyone. Thank you for this opportunity to share school eye health in SIB project in China. SIB Phase 5 Chair project was a comprehensive child eye health project, which was implemented between 2013 to 2018. In China, we have myopia rate for 6-year-old children was about 15%, and it almost doubled to 72% among middle school students from primary school children. And it further increased to 81% for high school students and 90% for college students. So myopia is really a public health issue in China. Activities conducted for school eye health in Chair project included school screening, included mainstream schools, special schools, and school for the blind. Children met the criteria were referred to hospitals for further examination, and treatment also provided to children confirmed in the hospital. Eye care professionals was conducted with school screening and in hospital and in order to the public. Screening conducted in mainstream schools included from preschools to high schools. School teachers or school physicians were trained in screening. So it was about over 1.3 million children had eye screening at schools, which included the vision test and simple eye assessment. Vision test was done by using a tumbling vision chart. The criteria and pathway was developed for referral. For simple eye appearance assessment was performed with pen light to see if there is any suspected abnormality, and by comparing with the other children in the class. Because children were in schools with teachers, so for most times, so teachers may notice their students' abnormality earlier than parents, such as squint, upper eyelid drooping. Our partner hospital also encountered some challenges for school screening, such as some principals refused screening with the excuse of students were too busy with study, and they thought academic performance is more important. Then we showed them the official documents jointly released by Education and Health Authority, and all we asked the hospital leaders to talk to principals. Another challenge for the school screening was children with good vision but poor functional vision, so were missed out for referral. There was an 8-year-old girl who was labeled by her mother as slow because she failed and she had to resit in grade 1. But by chance, later she was diagnosed with hyperopia and astigmatism in her town. So then after that, reinforced information was provided to teachers to pay more attention to their students, to observe their students. And to students, it is important to tell their teachers or parents if they could not see clearly or if they feel uncomfortable in reading or writing. And to parents that their children did not do well in study might also need eye tests. And also the training on functional vision assessment was extended to county-level eye doctors. Screening was done to school teachers as well. Screening to also conducted to all students in special school or school for the blind, but it's by medical educational team. So that like vision test refraction was performed by optometrists. Eye examination is by ophthalmologists with a slit lamp. But functional vision assessment was done by both optometrists and special education teachers trained through the project. Most children in special school were deaf and mute or with intellectual problem. So it is difficult to do screening for them. That's why for some time, partner did not understand why screen children with multiple disability. But when the screening was done in one special school, eye care professional was so surprised by high prevalence of uncorrected refractive error among children with deaf and mute or Down syndrome. They were so happy they could help these children just with spectacles. Referral criteria and pathway was included in the training for school screening. Children with presenting visual acuity less than 0.5 or with any suspected abnormality need to refer to local hospital. Referral for screening in special schools was based on visual acuity, functional vision assessment, and eye examination. The rate of referral uptake was low in the early phase of the project. Strategies we used included providing health education to head teachers because they were highly trusted by parents. Reinforcing the referral pathway among teachers and clinical staff. Encouraged to post the referral flow chart in screening room and in schools. Taking good care of school teachers' eye health should be a part of school eye health. We included it in the screening training for common eye problems of teachers, such as refractive error, presbyopia, diabetic retinopathy, glaucoma. This really motivated the teachers to actively engage in child eye health. Hospital regularly followed up with teachers or school physician for referral. Hospitals also provide children and teachers with preferential policy for eye care service. For example, registration fee exemption or free refraction. As you can see from the final evaluation, the awareness of referral importance was increased in the project. Further examination was provided to children referred from school. Treatment provided with for children with eye disease such as patching to amblyopia, surgical treatment to strabismus, ptosis, cataract, and optical service and free visual aids provided to children identified through screening. Free spectacle or subsidized surgery provided to families could not afford for the service. There was a misconception on surgery or spectacle. Parents did not want their child to wear spectacle because they thought spectacle would worsen eyes. And the teenager complained wearing a spectacle is not convenient for sports. Parents also did not want their child to have eye surgery before 5 because they believe general anesthesia would affect their child's mentality. So intensive health education was conducted to address misconception through social media, IEC material, or TV talks among parents, teachers, and children. Health education was embedded into screening, parents meeting, and promotion events such as Children's Day, National Sight Day, World Sight Day. So a lot of time and effort was spent on this. We also used the case study for health education. For example, a boy wanted to become a pilot when grow up, became an activist of myopia prevention in the class. After he learned he would not be accepted if he had poor vision. school eye health need joint effort of multiple sectors. So we looked for every potential opportunity to invite health and education authorities, well-known experts to talk at our project meetings. We recommended to create a national screening guideline. We advocated for annual school screening. We also advocated for shared child eye health information between education and eye care professionals. We are so glad that the project played a certain role of catalyzer for national myopia control campaign and policy making. A national campaign was launched a few days after the project closed. The National School Screening Guideline was released in mid-2019 and updated recently to accommodate to COVID-19 pandemic because online classes were provided by schools. This is the news released by MOH on 11th of this month, because there is growing concern about worsening trend in eyesight among children because increased the screening time and the limited outdoor sports during this COVID-19 pandemic. MOH suggests parents to take their children for eye tests before going to school, and also encourage schools to conduct eye test after the school reopened. So that's all I would like to share with you. Thank you for listening.
Thank you, Guan, for sharing all those strategies from the Child Eye Health Project in Orbis, China, and some really fantastic achievements that came out of that project. You're talking about that relationship between the Ministry of Education, the Ministry of Health, working with the School for the Blind Children who they just hadn't been worked with before, and with other children with multiple disabilities. Some great ideas around the sort of awareness raising for all levels, and then also the the national guidelines of what a long-term sustainable achievement that is. So thank you very much for that really comprehensive presentation of a wonderful project. And just a reminder for the listeners, if you have any questions for Guan, then you can start typing them in the Q&A box now, and then we'll ask them all at the end. So we'll ask all questions to both of our presenters at the end. So thank you, Guan. Now, thirdly, let me introduce Wardhana Dipa, Senior Project Coordinator for Eye Health, Helen Keller International. Wardhana, over to you. Would you like to share your screen?
Okay, I will share my screen. Okay, so I'm going to present about the school eye health activities that we do in the South Sulawesi in Indonesia. So the program is a work of a consortium consisting of CBM, Fred Hollows Foundation, Orbis International, and Helen Keller International. Each organization has their own technical expertise, and it is a collaboration of these 4 international NGOs. The Helen Keller International works at the primary and community level, where we provide trainings to the healthcare workers in the primary health centers and the mother and child health care. We also provide capacity building to the teachers, and then facilitate screening activities and do a small part of advocacy to the local government. Our partners, CBM, works to improve the capacity of healthcare workers at the secondary and the tertiary level, and also Orbis International works to improve the capacity of the ophthalmologists and other eye care personnel at the tertiary level. So the program aims to improve the capacity of health personnel in the field, so they can identify children with visual problem or any other eye problem, so they and then refer them to the nearest healthcare facility. The program works at in one province specifically, the South Sulawesi province, where there are 24 districts. This project has been started from 2017 until this year 2020, and it is run in phase approach, where phase 1 has been offered in 2017, and then phase 2 and phase 3 is an ongoing activities. We also have targets in the number of schools and teachers and screen students, and the number of eyeglass to distribute. When we start the program, we did a situational analysis, and we found that the government of Indonesia has already had a guideline for vision assessment in school. It is part of the school health program, and the school health program is to be run by the primary health center staff. This guideline is issued in 2015. When the program started in 2017, we knew that there is the national guideline for this. But we also found in the field that the teachers were not involved in this school screening, and then the primary health center staff is not trained by the Ministry of Health. So what happened in the field is that the PHC staff is they did screening based on the existing budget. So, and they did not do screening to all schools within their working areas. For your information, the primary health center is the spearhead of the healthcare service. They are responsible for a various number of schools within that area, and few number of mother and child health posts. So the number is very between 5 to 58 posts in one primary health center, and between 0 school or another primary health center, it is responsible for 109 schools. So in Indonesia, the health system is a regional-based system, where residents should go to the primary health center first as the primary service, and then they will be referred to the secondary level, which is the hospital. And the hospital type itself, there are three types of hospital in the secondary level. There are type D, the lowest level, and then type C and B. Type B is a type of hospital who is responsible for a number of district in one province. In South Sulawesi, there are 5 regional hospitals, which is responsible for the whole 24 district. What HKI does in this program is to increase the capacity of the school. We did a cascaded training. The first phase of this training is to train the district trainers. District trainers are individuals whom are selected by the district health office, and they should go, once the training of these district trainers is over, they should return to their own district, and they start training the staff from the primary health center. So there are three staff from all of the primary health center trained in the second layer of this training. And then the primary health center staff, they should train the teachers in the school, and then they should train a health volunteer in the mother and child health post. What the program expects is that there will be screening in the primary health center, and then there will be screening, visual acuity screening done by the teachers in school, and then also the health volunteer will also do screening to children aged 0 to 5 years old. We hope that when these three institution is capacitated, there will be an increase of awareness among the communities, the parents, and the teachers. We also hope that teachers who will be more actively involved in the visual acuity in the school health program. So for this model, SKI developed an agreement with the government and comply with the national guideline for training. To all the participants in the training, SKI provides modules and then videos and then screening kits for the school teachers, where they will be provided with condensed Snellen chart, and then there is a measure tape, and then there is also a pen light, and then there is a few numbers of education materials. The program also did sensitization to the headmaster and then the head of primary health center before the training starts. From the 24 districts, from all the trainings that Helen Keller has done at this moment, we've trained this number of teachers and from 1,300 schools. So these teachers, they have screened around 173,000 students from all over the districts. Out of the 173,000, there are the teachers identified 30,000 students who have vision problem. This number is now the target for the refraction service and the glasses distribution. So for the refraction and optical services, we found a few challenges in the field. The most important is that the local government, does not aware that refraction and optical services requires a certain permit. So in most areas, optical services are considered as any other business. It doesn't require any special personnel. It doesn't require any specific tools, any specific trainings. So even the district government is not aware of this the existing regulation. And then we also found the challenge that the lack of personnel in the field for the optical services. There are very few refraction opticians in the field, and most of them stays in Makassar as the capital of the province. And then within the national health system, eye care is not considered a very serious issue. When we talk about the eye care for children, it is not really considered as a serious or important issue in the current health system. So the program to the challenges, the program did the sensitization to the district health office, and then the program also invite various stakeholders and invite them in the table and discuss and introduce one to another. So there we expect there will be a linkage, a partnership between the professional association and the district health office. And then to also increase the capacity of the primary health center, the program did a training for GPs on the refraction services. So this is because the number of optical service in its district is very limited. In some areas there isn't any optical services, and citizen or resident has to go to another district to find glasses. There's a small part activity that we did an advocacy to the government to introduce optometry school and to encourage them to concern more about the child eye health issues. And from 2017 until now, the lesson learned that we found is that the primary health center staff receive or limited training on eye health and vision assessment. They require additional support. In some primary health centers, there isn't any tools to do screening, vision screening, and then training school teachers is effective to support the screening, the school health screening and the vision screening, and because teachers meet the student every day, and they are aware. With this training, they are more aware of their students' condition. And then we also found that the vision screening takes time. It takes energy and it takes space. And while the teacher's responsibility is not to screen this teacher, but it's not to screen this student, but they are aware. So it requires support from the headmaster. It requires support from the education office. And this and the last one is that we need more than just screening. We need to also think about the service delivery and the referral pathway. Otherwise, screening of these students are just becoming a data number where there is no follow-up step for these students. Yeah, I think this is all that we've learned during our project here for the last 3 years in South Sulawesi. Thank you.
Thanks, Wardhana. Again, another really comprehensive overview of the program that you've been implementing there. And some of the things that I really took from that is that importance of your the situational analysis at the beginning to kind of identify what the gaps are within the whole system, getting the referral system up and running, and I think really from both yours and Guan's presentations, the importance of getting your head teachers and your parents involved. So you're sort of looking at whatever the kind of the systems around the child at the center of that, what are those systems supporting the child. Of course, the challenge of the optical shops and lack of opticians, and how you've kind of worked through that as well. So yeah, I think another really interesting presentation. Thank you, Wardhana. Right, so we're now going to do the Q&A session. So yeah, Guan, great, we can see you now. So I've been reading your questions as they've been coming through, and I'm going to group them per theme. So if you'd like to ask questions, please do pop them in the Q&A, and we'll get through, we'll aim to get through as many as we can. So I'm going to start with the first one, which I think is relevant for both projects, which is around sustainability of services for children after the projects end. And it's from ANFAM. So what is the plan for your projects to sustain the school eye health program after Orbis or Helen Keller phases out? So Guan, do you want to start, and then Wardhana, you chip in after? Because I think actually it's relevant for both projects. That's all of our SiB projects. So Guan, do you want to start?
Yes, for this CHAP project, actually we started to address the sustainability right after the midterm review. It's just halfway of the 5-year project. So we first trained our partners how to use the data, how to analyze the data, like how many children referred from school screening, and how many of them actually came to hospital. And also we encourage them to build very good relationship with education, disabled people's federation, or schools, or even parents. And also another one is really in CHAIR project is very special for this eye health promotion. So a lot of time and energy we spend for that among, not only among parents, but also like we invited so many authorities, the leaders from education, from health authority every year, and sometimes every half year. So I think the relationship built between them, and like a WeChat group use this social media, they established the long-term relationship through WeChat group. So when they have questions from no matter it's from parents or it's from teachers or it's from our education or health authorities, so they actually build a kind of network, and it's easy to access. And particularly after the national campaign started for myopia control. So from what I know, the local provincial Bureau of Education, actually they become very active. They always like approach to hospitals to ask them to do school screening. And also when I found out there is a children with suspected eye problem, they will also send it to them to local hospital. So now, like through this project, the network is really established not only in hospital, in health system, but it's within health system, education system, and even disabled people's federation for those children whose eye problem cannot fix, but maybe can improve a little bit of vision through rehabilitation. I think, yeah, it's for Science Share project, we started to address the sustainability early, not by the end of the project.
Great, thank you, Guan. And Wardhana, same question to you.
Yeah, to make sure this project, I mean, this activity sustain after the organization leaves is, for our part, we try to invite the education office. And during our first assessment, all of this health activity is considered under the health office responsibility. So with the school health system, with the school screening, which, we invite the education office, and then also we invite, there is in Indonesia, there is an agency called the Coordinating and Planning Agency. So we also invite them and try to encourage them to put the school screening as an annual agenda for the school. If it is inserted in the annual agenda, then the local government will have to spare some fund to do the vision screening in school. We also try to link up the local government to the association, the ophthalmologist association, and then the refraction optician association, so they can communicate and support one another. That's what we do to ensure the school health activity is sustained.
Thank you. And actually, I think that your answers answer another question, which is around the multi-sectoral collaboration. And it's obvious that actually that's part of your sustainability, the fact that you've involved the Ministries of Health and Ministries of Education, right from the beginning. And I think, whatever the name is for essentially the Ministry of Disability, right from that, like you said, from Guan, from the sort of, from the beginning, from the middle bit, you were thinking about sustainability. Okay, so we've had, Wardhana and Guan, you can probably see we've had a lot of questions about referral rates. So we're going to try and sort of look at that aspect now. So some of our questions from Anil are things like, what is the time frame for follow-up, and what's done during the kind of the follow-up visit? And also from Niming, she's asking, we'd like to understand the referral rate from the teachers to the hospitals and the vision centres, and what tools are you using to kind of applying to increase those referrals? What are some of the key enabling factors? Something else. Yeah, so maybe something around how do you encourage the kind of the uptake of referrals? Because obviously we know that, you know, lots of children are screened and identified with issues in school. So how do you get them to kind of make that next move up to where they need to go to get referred? So Guan, can we start with you, and then Wardhana will move over to you again?
Oh, okay. For the referral rate time frame, so for chair project, we recommended 2 to 3 months after the screening. So we hospital will follow up with schools or teachers or physician through phone call or visit or social media, because usually at school time, so the school may be too busy to go there. So we will allow them like 2 to 3 months. But some hospital, they are eager to do follow-up. So mostly they do monthly follow-up with schools, but not directly with the parents, no, because maybe they are not happy for like disturb them. So referral rate from the school for chair project, in the beginning it's less than 20% actually. I mean the referral uptake rate. Really, they went to hospital. Then later increased to average is just about 30% of them, because some of them, they already had glasses, but although the glasses may be not good enough for the children, but they still, they are not going. So in most hospital, from hospital is different. Some very low and some very high. Some of them even they can reach to 70%, but average is only less than 30%. What strategy we used? We some hospitals said the head teacher is very important. That's why they hold a separate health education session with school head teachers to talk about why need to go to hospital to do further detailed eye examination, and why the students need to wear glasses. If not wear glasses, what will happen, such as like this. And also like it's through regular follow-up with principals or the teacher in charge in the school, like after 2 months, how many of your school children need further examination actually came to our clinic, and and also about the situation for those children who actually came, like they are like refraction diopter increased or not, or whether this child has eye problem, and whether the child with eye problem needs surgery. So during the follow-up, then the hospital staff will tell this person in charge, like, please talk to the parents, this child like need surgery for ptosis, otherwise because it will affect the school performance, something like that. And another is still the health education, eye health education. Sometimes use samples, use like there is a child also sit in grade 1 for 3 years just because of ptosis, and the school teacher, they don't know the child just looking up the blackboard by lifting the head. They said, oh, this children is so slow, they are different, he is different with other people. So sometimes use case study is good to convince other children to come for take service. I think, yeah, what I would like to share with you from chair project.
Thanks, Guan. Yeah, and really that emphasizing getting everyone on board, and you know the data, so you actually can track and trace, you know, where those children are, you know, where they're sort of dropping out of the system. Thank you, Guan. Wardhana, what's your input on this same question?
Yeah, actually, we haven't been able to count the referral uptake. even when the teacher found that his or her students have a vision problem, they send a letter, or they verbally inform the student to inform their parents, so they can go directly to the primary health center. So in Indonesia, the system is citizen has to go to the primary health center first. They cannot go directly to the hospital unless it is emergency, or it is not unless they don't use the national insurance system, so they can go directly to the hospital. So most people here, they go first to the primary health center, and then unfortunately the record in the primary health center is not that good. So we've been trying to trace how many students came to the primary health center by name, and it is very difficult to receive the notes from the primary health center staff here, from their administration. We've been also trying to trace how many students came to the hospital, but it's very difficult. It's very difficult to trace exactly how many per name, per school, per district, per sub-district, how many students really, how many identified students who really came to the primary health center and then to the hospital. An easier system is to open the data from the national insurance, but it is prohibited, and if it is a very difficult administration to go through the national insurance system. So we don't have at this point, we don't have a specific percent, or we don't have a specific number like Ms. Guan did in China. We only heard the stories from the primary health center that this week we found there are 10 children, 5 children, 20 children came to us, or in other occasion that the ophthalmologist in the district text us as there are children with this condition. They say they were identified by the teachers and asked to come to the hospital. That's the data we have at this point. Yeah.
Great, thank you, Wardhana. So I make it about, we've been going for about an hour now, but we still have quite a few more questions. So I'm suggesting that we continue for about 10 to 15 more minutes. But obviously if people do need to drop out, then feel free to. But we've still got so many questions that I want to just take a little bit more of your time to kind of answer another couple, if that's okay. So we've had a few questions, Guan and Wardhana, on spectacle compliance. Obviously, that's sort of the key end bit, isn't it? You know, you sort of screen children, you've refracted them, they've got their spectacles, but how do we know that the children are actually wearing their spectacles in the school? So one of the questions to you both is around, you know, do you know your percentage of spectacle compliance, and what do you do to encourage that? And I think also a bit of a connected question of how do you manage the quality of the spectacles you're providing, and who is paying for them? Is the project paying for, or how do the spectacles get paid for? So I'm sort of going to group all those questions as one around sort of quality and cost of spectacles. So Guan, can we start with you, please, on that one?
Yes, sure. For spectacles compliance, we don't have that indicator in the project, but we really, during our quarterly visit, we asked teachers and our local partners. So we notice in rural area, like at town level, we have some schools, essential schools, primary school in township level, not county city level. So it's low. I think they told us, for the newly identified refractive area, maybe just 40% parents will let their children to wear, because they said, oh, wait until you're in grade 8. Then when the child almost grow up, then they said, okay, now you can wear. we are surprised. We said, why the parents have this misconception? When the children grow up, they can wear spectacle. So in rural place, it's low, but at the county city, so it's a bit of not urban, but it's better compared to the village or town. So the spectacle compliance is average about 80%. So it's kind of good. And it's particularly after the health education, it's much better. And for spectacle paying, in chair project, we have some free glasses, but only for those children who cannot afford. So it's about 15 to 20% of total. So mostly they pay for by parents. And also another thing is because in this project we ask hospitals set up different price. It's like a tiered price for spectacle. There are some very cheap one, particular at the county level, county city, maybe it's just less than $2 for one spectacle. So parents, it is okay. And for very poor one, the project providing free classes, so it is okay. Oh, I would like to mention another thing I forgot for the first question. Because the referral uptake is low, but it does not mean the children didn't get service, because we have some optical shop on street, so parents are going there. It's good we have a data system, so we aimed to check that one, but like previous mentioned, it's difficult to check. But from our project, we noticed 2 counties, their project manager, they did great work. So they asked those children, a teacher on the children on the referral list, whether they went to other place. Then they filled up in the database. So when we analyzed the database, we found out actually almost another half went to optical shop, because they said it's very easy. They don't need to put eye jobs to dilate pupil. They just go there and they try. If they can see clearly, then we take it and go to school. So it's not mean the low referral rate in hospital mean children didn't get spectacle. So that's all I would like to share. Thank you.
Great, thank you, Guan. Wardhana.
Yeah, from our experience here, I mean, with this project, the glasses is provided for free. So of those 30,000 children, it is a early identification, a screening by teachers. So that's why we collaborate with the professional association, the ophthalmologist and the refraction optician. So we set up a sort of refraction days, refraction camp, where we set up a schedule which school came to on which day. So these children are invited to the session where they will be examined by the professionals. So related to the quality of glasses, since we rely, the project relies to the professional association, because they are the one who has the skill, the capabilities, the legal power, yeah, to determine whether the spectacles is standardized or below standard. We rely to this professional association. That's it, yeah, about the quality of glasses, yeah. Yeah, okay, thank you.
Great, thanks, Wardhana. And I'm just going to ask one final quick question to both of you, which is around out-of-school children. Do you have specific strategies for reaching out-of-school children? And then also, given the situation that we're in at the moment, do you kind of anticipate that there will be less school attendance after this kind of COVID pandemic? And how do you think programs will need to adapt to kind of reach them?
Sorry, can you explain why this out of school? It's mean what?
Children who are not in school at the moment. So if there are any children who are not attending school, who are kind of staying at home, do you have this issue? And if so, how do you reach those children?
Yes, during this COVID-19, like in Chair project, although it's finished, closed, but our partners still, they send messages through WeChat group, telling teachers or parents if the children have eye problem, if it's really cannot say clearly, so they can make appointment through WeChat. Like hospital has official WeChat account, so make appointment with hospital, and the hospital, because they have this they took some measures for this COVID-19, like they control the number of visits for patient visits, and also they have some shield when they check the children's do refraction, like they put a shield between eye care staff and patient. But yeah, it's less, but still, if they feel they need to go, they can make appointment with a hospital. And for some, and they can do before the parents take the children to go to hospital, actually they can do consultations through WeChat, like asking questions whether they need to go. So it's easy, and they are trying, some of them trying to use kind of vision acuity measurement through WeChat, teach the parents how to do that, how to, it's like estimate, not very accurate, but can avoid whether unnecessary to go. But if really need, they can make appointments through WeChat.
Thanks, Guan. Wardhana, how about you? Are there many children who are not in school even before the COVID pandemic? Were there children who were out of school? How are you reaching those children?
Yeah, actually, there's another offices, ministry that we work with. We said the Health and Education Office. We also work with the Ministry of Religious Affairs. In this case, they are responsible for the preachers, for the pastors, for the religious leaders. So we did a sensitization to the district, at the district level, the district office of religious affairs. We hope that they will forward this message to the local preachers in the villages, and also for these out of school children, the health volunteer, the health volunteer whom were trained earlier. Basically, they are usually they are an active individuals in their neighborhood. So they would spread out the message to their neighbors, to other parents, to their siblings, to their family members. That screening, the vision screening for children is important. So yeah, the project tries to spread out the message that vision screening is important for children. That's what we've been doing so far in this project.
Great, thanks, Wardhana, and thank you, Guan, for excellent answers to a range of questions on child eye health. I wanted just to see if we've got Satya back online, if you wanted to make a couple of kind of final comments before we go over to Sally. Let's just see if you're, if we can hear you now, Satya.
Can you hear me, Susan?
Yeah, I can hear you clearly.
Is this good? Okay.
Yeah,
just to summarize what we've done in Indonesia around sustainability. One of the main ways to make sure that the activities for screening at the maternal and child health posts and the school activities take place is by integrating the activities into programs that are already existing. So because the you know, the maternal and child health post screening, it's an integral part of the activity at the primary health center. These, you know, children from 0 to 5, they are, you know, constantly seen at these posts for immunization, for growth monitoring, and also for, you know, making sure that, you know, breastfeeding is carried out. So this is where, you know, the sustainability is, because, you know, the screening function is also integrated into the activity at the maternal and child health post. And similarly for the school health program, because you know, the school health program is already existing. So just adding and training the teachers to do screening, providing them the tools and the capacity to screen their students kinds of integrates the vision assessment piece into the school health program. The other way to ensure sustainability, Wardhana already mentioned, was to establish linkages between the professional associations, the provincial health and education office, and the district health and education office, and also budgets. You know, reallocation of budgets for screening purposes is very important, and that is where advocacy comes in. Another effective way of doing this is by analyzing what it would cost for screening, and that's what we're trying to do now. We're trying to analyze the costs for screening students and for training teachers in order to sustain a good school health program. I think the rest of the issues have been answered by Wardhana. It's just the refraction service and the optical services that has been extremely challenging in our setup because of deficiency of service providers. We don't have optical shops in remote areas, and most of these districts, except for the 6 main cities, all the other 18 districts are all extremely remote. So that's the reason why we train the GPs who are based at the primary health centers, who can take up some of this load of refraction. And this is also a slow process, so to kind of integrate this whole thing into the system is taking a little time. But I'm sure, even regarding the data, we've not been able to track children through the primary health services, through the secondary and tertiary levels of care, but that is expected. And I think Indonesia is not alone there. Recently they've started collecting that data for eye health at the primary health centers and at the maternal and child health posts. And these are still early days. So they need to kind of expand it from the primary level to the secondary and tertiary levels. And I hope that happens soon. Thank you, Susan.
Great, thank you, Satya, for that input as well. And that's really, I think, an important point to flag is what are the systems that are there at the moment and how can we kind of get eye health into that. So thank you. I'm glad we got you at the end. Thanks for that. Okay, so finally, I'd like to introduce Sally Crook, the SiB Programme Manager, for some concluding remarks and wrapping it all up. Sally, over to you.
Okay, thank you. Well, thank you to two great presentations. And I think both of the presentations and all the questions and the replies to the questions have really highlighted how child eye health, or school eye health, if you're going to have a subsection of child eye health, is much more complicated than it first looks. And every country has its own particular good starting points, like to hear that Indonesia had a school health policy, or that in China there was a very good tertiary hospital where they started working and things. So there's often a lot of good going on, but it's just not joined up, and that there are so many local preconceived myths. I'll call them myths. Guan mentioned a few, parents saying, oh no, the child can't go to surgery until it's 5 years old, or it can't wear spectacles until it goes to secondary school, and all these sorts of things. And until you start working and really plan very carefully where you need to put your effort, to look at all these myths in the families, in the community, and in the professionals. And I think when I visit the child eye health projects and the school health projects, the one thing I'm struck everywhere is always there will be several members of staff, both in the Ministry of Health and the Ministry of Education, who will say, "This is wonderful. I never realized either what I could do or how I could help or where these children can go to get help or that help is available." And there is always these lovely, lovely sort of light bulb moments. And the more light bulb moments you can get, especially in the policymakers or the planners, this is wonderful. And I think, you know, seeing is believing, we took a huge gamble to say we are going to have these quite large child eye health projects, but it's enabled the team. And as Wardhana said, you need a team of lots of people with lots of different technical skills and expertise to really explain at a sort of a, you know, as we say, the child eye health level of sort of 1 million population, what you can do if you all start working together. And the other thing I'm quite excited by is also most tertiary hospitals I've been to, they've again said, this has been great. We now have numbers increasing, you know, because at the beginning when you're saying to them, you need to help train your secondary hospital staff, or you need to, you know, help us develop guidelines for screening children, they're kind of all seeing it as, oh, this is so much work. And but at the end of the day, they kind of see, yes, this was worth it. Now we're getting proper referrals. You know, the ophthalmologists are seeing children who need surgery. The pediatric optometrists are seeing children with complicated refractive error needs. And the tertiary hospitals understands that, yes, they are the tertiary center that needs to deliver the more specialized services, and all the other things, the conjunctivitis can be dealt with at a primary health post, if that's what's available in your country, and also engaging the whole ministry to look at how they can help the children long term, and how eye health for children can become part of maybe the insurance package, the services that are provided at the district level, you know, at the health post level and things. And I do see that in quite a lot of places, we've really had lovely light bulb moments. And when I get the reports from you all every 6 months, often, you know, there are little incremental changes. You know, you're reporting that the governor of a district or of a region or something has said, yes, we need to encourage the schools to do the screening, or we need to look at how the health staff can also consider the children who are coming, as Satya said, for their immunizations or for their growth monitoring. We need to pick up the children who have eye care problems much, much earlier and make sure they go to the services that are available at the secondary and tertiary levels. And it's a big problem, and always more and more problems come to light as you progress in the project. But I think the projects are leaving some really good learning, and there've been other questions about the cost effectiveness and things. And again, these bigger projects have provided data where, you know, somebody's been able to look at the data and look at some of the costs involved and the additional costs that it would be to a ministry planning services long term and things. But I'm really happy that some of these child eye health projects have done some great research on the back of large data sets that you now have. And as you say, there are problems with the data, but in all of them, I think things have been greatly improving. And I'm very happy that, you know, things are moving on. I'm very conscious of time. Thank you, all of you, for staying on a little bit longer. I was just asked by IAPB to say a few things about COVID at the end. And there are a lot of COVID materials on the IAPB website. You can just click on the IAPB website or on my, you know, my signature at the end of my email or Susan's email, and you'll go through to find lots of COVID resources. And there were a few questions about some of the COVID issues that Guan raised about in China, that the you know, there is an awareness that having had the children at home looking at a lot of, you know, laptops and tablets and things and phones, that, you know, maybe their eye health has declined in this period. So what I would say is, yes, there are a lot of materials on the IAPB website, but also please check your local national guidelines. You know, this will be about, can you do non-elective surgery? Where do children go if they have a sudden emergency, you know, put a stick in their eye or something? Where would you send them? But then when can you get back to the more elective issues, which also includes screening? And when will that be able to restart? And you need to know your local guidelines, because every country is different in this COVID pandemic. And please do check with your national guidelines as to what is happening, and prepare people, and you know, be sure that when things are ready to start again, that the local providers are ready to start again as well. Thank you very much. Okay, well, thank you.
Thanks, Sally, for the impossible job of summarising everything in a few moments. Wonderful, thank you so much, and thanks for just flagging those COVID resources as well. That's great. So we're going to end the webinar now. So I just want to end by thanking all of our presenters, Yuddha, Guan, Wardhana, Satya and Sally, for their comprehensive presentations and really comprehensive responses to all the questions. If you had a question that you kind of feel wasn't answered, you can email it to me and I can forward it to our presenters if there's still sort of, we did have a lot of questions, which is great. Lovely to see people so engaged. Thank you, Holly, for all your technical support. And thank you to everyone who's participated. As I said earlier, I really appreciate you taking the time to sort of be part of our SIB learning community. Just one final favour, I'm going to email you the SIB webinar survey now. If you just take 5 minutes to complete it, that would be really helpful, because your support makes these webinars possible and your feedback helps us to improve them. So thank you all. Thanks to all our presenters, thanks to our attendees, and have a great rest of the week. Thanks all, bye.